This is a very important topic. You may not see many cases of this throughout your career. I think women probably will see more, but you can really make a huge impact to the lives of these often very young women. So it's worth hearing more about. So I'm just going to backtrack to menopause, which is the last period. It just means there's no more eggs. So the last egg, the last period, it often gets clouded by being on the pill, having a Mirena in, other circumstances, or having a hysterectomy, but it is the last egg that's ever going to be released. The median in Australia has not changed, 51 to 52 years, but normal is 45 to 55 years. And some women come to me even at 45 and say, I feel like I've been robbed of 5 or 6 years of my life because I was meant to undergo menopause at 51. So some really feel menopause, and that's why I try and remain my passion for menopause, because you can make a huge difference. So early menopause is menopause less than 45 years of age, and 5% of women will undergo menopause before that, but premature menopause is menopause less than 40 years of age, and you as a group have referred women to me who've been as young as 15 or 16 and their ovaries do not function and will not function again. So you can see there's a huge impact if someone has this at that young age. I've had women in their 20s, and it's not uncommon. You refer to me, so I see more, but you will come across a few cases over your career. So it's about 1%, and there is a higher incidence in several groups. Smokers will have an earlier menopause, typically, and a higher risk of premature menopause. So if they're not listening to anything else, and they're trying to get their fertility working, that's one thing you might have to try and get someone to stop smoking. Nulliparity, interestingly, is connected. Hysterectomy or any sort of gynecological surgery that might be invasive, if ovaries are disrupted, then they're at higher risk. HIV infection, illicit drug use, and adverse life events, so poor social circumstances, trauma, etc., can also bring this on. So I'm just highlighting this really just to show you, and I'm sorry, a few things have moved there, unfortunately. That was not my design. I'll try and fix it up for the next talk, Ramesh. So I'm just really highlighting what estradiol does over the reproductive, over a cycle. So at the start of this, and I think I'm trying to use mouse here. Is my mouse working? All right, I'll take you from the left of the slide. The left of the slide is where periods happen, and that's the start of the cycle. Estradiol at that point is typically low, and it will depend on the assay that measures it, but it's about 150. You'll see there in the orange loop, the estradiol there's a huge increase up to about 1,500, so a 10-fold increase. And you can also see there on the slide that estradiol levels are not static. They're increasing every day because the egg is producing that estradiol. So when you run out of eggs, you run out of estradiol. So the postmenopausal level of estradiol is about 20 if you do a very sensitive assay, and the average estradiol that a woman is meant to be covered by over her reproductive life from 13 to about 50 is 400. So if you get a 16-year-old whose ovaries are never going to work again and she has a level of 20 for estradiol, there are going to be health consequences for her because she hasn't been exposed to that average amount of estradiol that was expected. So why is this important? 40% increase in risk of cardiovascular disease and a 2 to 3-fold increase in risk of osteoporosis and fracture. Obviously, when you see a 16-year-old with this, you can't sort of talk about these things. They don't get it. They're busy being a 16-year-old and busy trying to cope in a world that throws up a lot of challenges at that age. But these are things you need to be very mindful of, thinking, I can make a difference here and that girl can have a very different future. Cognitive decline and dementia, there's a 2-fold increase in risk. Also type 2 diabetes, Parkinson's disease and glaucoma, interestingly enough. I'm not sure what the link is there. And this is really the relevance. I've looked into cardiovascular disease in women recently, and it's the biggest killer of Australian women. 32% of women in this room, or maybe not this room, will die of cardiovascular disease. And you don't want to be doing it when you're in your 40s. So really, that's where you can make an impact with these much younger women with premature menopause to try and prevent this. So there are lots of causes, and I do a lot of tests. When you refer them to me, I do a lot of things, and almost invariably they're all normal, but a few times you'll find something that will really be an important impact for the family. For example, there you can see under genetic and cytogenetic Fragile X. So if that lady is a Fragile X carrier, that has implications for her children, or if she could conceive for future children and for other family members. So that's an important part of this. But all the other things, enzymatic defects, immune disturbances, etc., you just don't see a lot of those. More and more we're seeing women who are being treated for endometriosis or for cancer. They're receiving chemotherapy or surgery for endometriosis, and that's another group where you do see premature menopause. So women who might be menopausal, say at 35 or so, because of those things as well. And as I mentioned before, cigarette smoking. But more and more idiopathic premature menopause is the most common cause. So there is also, this is a very confusing subtopic in premature menopause called primary ovarian insufficiency, or POI. Also confusingly, it was previously called POF, or premature ovarian failure. Because we don't like labelling patients with a word like failure, they have therefore renamed this, but it's the same thing. So 90% there is no cause, but there are genetic links and quite strong autoimmune links. Fragile X carriers, for example, are in this group, and Turner syndrome too. They are at quite higher risk of developing autoimmune conditions. So 1 in 4 will develop hypothyroidism. That's quite high, isn't it? Adrenal insufficiency or type 1 diabetes will occur in 3%, pernicious anemia, myasthenia gravis, connective tissue disorders, and hypoparathyroidism. So in the workup for looking at causes of premature menopause, we do an autoimmune screen, and that might point you towards, for example, I've had a lady recently, nothing else was askew, but she had very weakly positive thyroid autoantibodies. So therefore, that was my key to say, well, I think this is some sort of autoimmune cause of premature menopause. So this is also a tricky area because intermittent ovarian function may occur in about 50% of these women. And therefore, they might have had no periods for 10 years and then just one out of the blue and have breast tenderness and PMS before it. And that is release of an egg, and that's a period. So it's very difficult to say, well, you're not having any more periods again when they might happen. And spontaneous conception can happen in 5 to 10% of women. And I've had one of these ladies with premature ovarian insufficiency. We've been discussing her HRT when she's been breastfeeding her baby. So, I mean, funny things happen here. But it is a sort of a hope, because a lot of these women will come with fertility issues, devastated about fertility, but they can menstruate spontaneously at times. You don't want to rely on that though. They also have a higher incidence of anxiety and depression, hence psychological support's really important, low self-esteem and isolation. They feel different from their peers, their fertility has taken a back step, and meeting a partner is difficult. What do you say when you meet someone? Let's go on a date, but by the way, my ovaries don't work and we'll never have children. And when do you tell that partner? That's also a very difficult decision. I know I've encountered all of this. So you really need to support these ladies quite a lot, no matter what age they are. And when they come, when they're in their teens, you also need to support the mother, because the mother will be sitting next to them and will be devastated that the teenager won't often get what's going on. So the key issues, I think, diagnosis can be very difficult and delayed, and I'll take you through that. Education is really important, and there are some great tools, and I'm going to do my sneaky saleswoman trick there. Symptom management, very important. Fertility management, psychological support. So you really are the linchpin here. You can really gun this and get it right for the individual woman if you just consider these things and just be aware that there can be other problems. Prevention is also important. So you can look at the problem now but think, well, your life is going to be different now because of cardiovascular disease, osteoporosis, and possibly cognitive decline as well. So estradiol has nothing to do with the official diagnosis, which I think is interesting, but it's diagnosed with an FSH more than 40 international units per litre on 2 occasions at least 1 month apart following 4 to 6 months of amenorrhea and not clouded by HRT or the pill. And I've seen some of your letters that have said that the girl comes in or the woman comes in and you can quietly see that there's these huge FSHs of 80 or 90 or something, and I can see that you're terrified that it's premature menopause, and it probably will end up like that. But there's a very complex stage of working through that with the patient, because you can't get a level of FSH of 80 in a 16-year-old and say, oh, by the way, I think you've got premature menopause. You really need to carefully work it out and say, I don't think your ovaries are working very well. We need to carefully sort this out before you label them with something. We do also need to exclude secondary causes of amenorrhea as well. Hypothalamic amenorrhea is a sort of a safety valve shut off where the body thinks that it's not going to survive a pregnancy or the baby won't survive a pregnancy. So the hypothalamus will stop sending messages to the pituitary will turn off the ovaries just to say, right, we're not getting pregnant now. These women tend to be lawyers or doctors or children of lawyers or doctors or that sort of person. Everyone's giggling because you know them. High levels of exercise. They're a very wound up type A, anxious type of person, often, not always. They may have a low body weight or BMI, be very focused on diet, calories, nutrition, paleo diets or whatever. Please don't feel I'm not labelling, but this is what I've seen. And they do have, the distinguishing feature here is they have low or suppressed FSH and LH levels and quite low estradiol levels. And they're another group that we need to intervene. We don't want those ladies sitting there with no estrogen. They're a key group. I'd love to give a talk on that one day. But you must exclude this. Hypothyroidism, pregnancy, big cause of amenorrhea. Kathy knows that well. And polycystic ovary syndrome. So it's often, there is some work required on initially seeing them to work in this out. But that FSH being high is a key pointer. So this is the initial stage of investigations, and I think this is very reasonable for you to do. Estradiol, FSH and LH levels, prolactin, that can cause amenorrhea, as you know. TSH, testosterone really is necessary because it's a measure of ovarian function. So ovarian function, testosterone is made by the ovaries, and often testosterone will be very low in these women, and some women will benefit from having testosterone treatment. So I would do those. And SHBG is sex hormone binding globulin, the protein that binds very tightly to testosterone. DHEAS and cortisol, more to look at the adrenal causes and to see if there's an autoimmune link. Addison's would be one of the things to exclude. Thyroid autoantibodies, fasting blood glucose, a vitamin B12, again looking for autoimmune causes and pernicious anemia. A beta-8-CG, if you think, well, it's pretty easy to do, isn't it? And a gynecological ultrasound to see, are there follicles, what the ovaries look like, what the endometrium looks like. And sometimes you'll be surprised to see what's going on. So AMH, the women will typically, there's a lot of lay knowledge about AMH. They'll want to have a level done. It doesn't help. It's not necessary for the diagnosis. And it might be just another bit of bad news when they have a very, very low AMH. So I don't really use it. And you just take them through, no, we don't, there's a lot of issues with assay sensitivity, and at this initial stage we don't need it. The diagnosis can take time. For example, if you need your 4 weeks apart of the high FSH levels, and then you need to refer to a specialist, that will take a wait, and then the specialist will organise more tests, and they'll typically take 4 or 6 weeks. So there is no instant diagnosis here. And there's a lot of anxiety, and it's just being very understanding, supportive, supporting the mother and the family, and just taking it bit by bit by bit. I would refer to a specialist or a tertiary referral centre. Here in Melbourne, we're very lucky to have 2 very good menopause clinics at Monash and also at Royal Women's, or a gynaecologist or endocrinologist who is passionate about this area, knows what they're doing, and really can take these women through their life, really. Fragile X and chromosomal analysis should be done at that stage. They will be out of pocket for those costs, and they can be up to $400, so I don't think that's worth doing initially. DEXA scan I would do at that point, and adrenal autoantibodies as well. So in terms of symptoms, 80% of symptoms will be all of these symptoms that women typically get in menopause. The flushes and sweats, sleep disturbance, vaginal dryness is a very key important point. So if you see someone with premature menopause at 16, that's very important in terms of looking at sexual function down the track, or they might be sexually active, and addressing that and asking them, because it might be something that a 16-year-old might be hard to talk about. Other symptoms, that formication is the crawling under the skin, joint pains, difficulty concentrating, irritability, fatigue, anxiety, palpitations, low mood and low libido. So they don't differ as a group. 20% of women will have no symptoms, and some of these women will sneak through your door saying, I haven't had periods for 10 years, and they're 35 or 45, I don't have any symptoms, you're telling me I need the pill or HRT, I don't have a problem, I don't need that. So there's actually a bigger battle if they don't have symptoms, and I've had many a conversation with these women. Yes, no symptoms, you're doing well, but your estrogen is very low and there are going to be consequences down the track, and we want to prevent all of these. So it's often better if they do have some symptoms, because it's a big battle sometimes. So the treatment is sort of easy. It really depends on the cause, and I've said that because some will have premature menopause because of treatment for breast cancer, etc., and estrogen clearly is not indicated and it's contraindicated in those women. But unless there is a contraindication, we do want them to have some form of estrogen and progesterone replacement until around the age of natural menopause. And some studies say that's 45 to 50. I usually will say 50 years of age because that's closer to the median age of menopause. And again, if you think they're coming in at 16 or 20 or whatever, that's a long form of hormone therapy. That's why the pill may be more beneficial in those younger women, more in line with their peers. It also offers contraception if a pregnancy isn't desired and they have premature ovarian insufficiency. I know that sounds weird, but and it's peer appropriate. They're more accepting of it. They all think, if you give me HRT, my breast cancer risks are elevated. So there's a lot of counselling we need to do about that. Estrogen and progesterone if there is an intact uterus, but if they've had a hysterectomy, they only need estrogen. We do favour higher doses if we're using MHT or HRT, just because, remember back to the slide with the estradiol levels, they would have been covered by quite a lot of estradiol, and we think that in preventing heart disease, bone loss, etc., they will benefit from higher doses, and it will really depend on tolerance. There's a lovely guide to equivalent doses of MHT or HRT on the Australasian Menopause Society website, and I have a link there that will tell you what is a low dose, what's a higher dose, what's on the PBS, what's a combined product. It's a very useful guide. Vaginal estrogen is very important, and there's some good products, and it's just telling women to use them regularly. So Vagifem will often sit in the cupboard and be used every now and then, or Ovestin or whatever. They just use it twice or maybe 3 times a week if there is a lot of vaginal dryness or urinary tract infections. There are vaginal moisturisers and lubricants, and I can sneakily tell you now about the Jean Hales menopause tool. This is being updated, but you can go to the Jean Hales stand. I am like a crummy saleswoman. This is some really good information here. There's a similar tool about endometriosis as well, and this is almost about to be updated. You can put your name down at Jean Hales and they will organise to send you one, but you do need to go and see the girls there. This is a really good information sheet because you can put it in the drawer. It has special situations, things to consider, and it is relevant for premature menopause in that it's guiding you about hormone therapy. So I know that's my cheap stunt there. Testosterone will be favoured in some women in terms of their levels will typically be low and libido will be an issue. Testosterone will improve bone density as well. So some will just say, yes, you get the whole lot. It is controversial and you need to go through them. There's some good information on the Jean Hales and Australasian Menopause Society website more about testosterone. So the benefits of hormone therapy: symptom relief if they have symptoms, reduced risk of cognitive decline. We do know that from studies, reduction in fracture risk. But interestingly, I searched around, there is no study evidence that they have a reduction in cardiovascular disease risk, but we presume this from studies of natural menopause. So this was a neat little study. Because this is not a frequent condition and because they tend to be scattered through cities or whatever, it's hard to do a study of women with premature menopause or premature ovarian failure. So this was a British study of 30 women, which I thought was interesting, aged 18 to 44 with premature ovarian insufficiency. They used a standard HRT product with estradiol and norethistone acetate orally versus a common garden pill versus no treatment at all. And they followed them for 2 years. So the messages here are interesting. The only treatment that improved lumbar spine density was HRT. There was no change with either treatment in femoral neck, but it didn't reduce. And both types of hormones reduced bone turnovers, which meant that, bone was not being lost so quickly. The pill kept bones static, and you'll see that no treatment, even at a very young age, they were losing bone and their bone turnover markers were higher. So any form of hormone therapy will work for bone, but HRT, interestingly, maybe because it's the exact same estradiol that we had before menopause, improves lumbar spine density more. So that's another consideration here, and we're learning more and more about this as we do more research. So this is the risks and benefits of MHT or HRT between the ages of 50 to 59 years of age. This is the typical thing I will take women through when they're freshly menopausal at around 50 and say, this is the benefits on the right-hand side of the slide and these are the risks of HRT on the left. But we can't really apply these to women with premature menopause because they're not 50 to 59. They might be 20 or 35 and they might get very caught up in, you give me HRT, my breast cancer risk is increased. You must tell them that you were designed to have a typical estradiol level of around 400 throughout your reproductive life until around 50 years of age, and we don't look at these risks the same way as we look. So they are appropriate for HRT, but there'll be a lot of barriers to that uptake, and it's a very careful discussion, and I've done that careful discussion, as I'm sure many of you have. So this is the Framingham study, which Framingham is a little community in the US where they don't move. They're happy, they like it there, and they just plonk. So as you probably know from previous talks, they keep studying them over time and they've got some lovely data. But these were the first people who found out that women of the same age, there was a difference in cardiovascular disease incidence, and that came about with menopause. So you'll see the red bars there, the postmenopausal women, even at the same age, had a higher incidence of cardiovascular disease. And that's where we really, the whole thing about estrogen and cardiovascular disease came about. But there was a lovely study following from the WHI. We've tried to look at different forms of HRT or MHT, and we've tried to look at what the impact of early intervention versus later intervention, where the difference is. So this is the ELITE study that was released last year. They had a group of early menopausal women and later postmenopausal women, and they were within 3 years of menopause, the early ones. They followed them with oral estradiol, so very different from the previous big MHT studies, and they looked at carotid artery intimal thickness as a surrogate measure of heart disease, because you can't study heart disease events in this group. They're too young and they just don't have that number of events. But I get very excited about this slide, and you might not be less excited, but the upper bars are the later postmenopausal women. You'll see there's no difference between placebo and the estradiol-treated women, which was sort of comforting. There was no increase in risk of cardiovascular surrogate endpoints with estradiol treatment. But the other important thing is the lower bars there. You'll see the P with the green arrow. The women who had estradiol, who were fresh to menopause, did not have hardly any progression of carotid artery intermedial or medial thickening, but the women on placebo did. So there was this window of opportunity where you intervene with estrogen early, you have a cardiovascular protective effect. And that's the very important thing, again, to say to women at 16, 20 or whatever, This might not make sense now, but we're trying to create a different and healthier future for you. So other management, you're very good at this. Psychological support is imperative, and a care plan would be brilliant to give them the 5 psychology visits if you think it's appropriate. And they need some form of psychological support with someone who understands the area as well. That's the important thing. Fertility counselling is also necessary, and a 16-year-old, it's hard. I sort of say, down the track, when you're looking at having children, this might be a challenging area. We're going to look at this down the track, and there are options for you. So it's hard to tell. When they're in their 30s and want to conceive now, then that's a different issue. But referral to a specific fertility specialist with an interest in this area. Donor egg, for example, might be something that they do, and some of those women will conceive with premature ovarian insufficiency. Sexual counselling may be an issue as well, so think of that and refer off. The normal things for cardiovascular disease and osteoporosis: risk reduction, apart from hormone therapy if appropriate, avoiding smoking and alcohol excess, encourage weight-bearing exercise, adequate calcium in the diet and vitamin D, do your general screening that's normal for age appropriate, breast exam, etc. Osteoporosis medications may be necessary if they have osteoporosis and fracture, or if hormone therapy is contraindicated. Non-hormonal treatments for flushes and sweats, if they do have a history, for example, of breast cancer or other cause that they can't use HRT. There's a lovely information sheet, again, at the Australasian Menopause Society website about non-hormonal options for menopausal treatments. And typical agents that have been used: venlafaxine, others of the SSRI group, clonidine and gabapentin. So different medications that will help flushes and sweats, and are difficult to discuss with patients, but when they're better, they get it. So take-home messages. Premature menopause is not common, but is associated with increased risk for cardiovascular disease, osteoporosis and cognitive decline. Unless contraindicated, women should be offered some form of estrogen and progestogen if they still have a uterus. It can be HRT or MHT, as it's now known, or the pill, combined pill, until the average age of menopause, and I would say 50 years, even though some of the studies say 45. Women with premature menopause should be assessed by someone with expertise, and I will typically, once they're on their way, we've sorted it out, they're happy, I'll see them maybe every year or so when that's appropriate. Psychological support is imperative, and fertility management, in addition to the normal management of a woman who has undergone menopause. There are lots of great resources. The Gene House is a lovely website on premature and early menopause, plus the bag with the goodies and the tool that you can order. Still a cheap saleswoman. And also the Australasian Menopause Society has a brilliant information page on their website, freely available, on spontaneous premature ovarian insufficiency. It's very hard to find an information leaflet that doesn't mention the word menopause for someone who's 16. I think we'll work on making one of these. So at the moment, these are probably the best sources of information. There is a fantastic conference every year. This year it's in Sydney in October. I'd love to see you there. If you do a lot of women's health or do menopause or are interested in how to do HRT, hear more about this. We are going to be exploring the evidence with regard to menopause, but it's not just menopause, it's looking at midlife health and beyond. And this is a very worthwhile conference, and I'd love to see you. Thank you so much for asking me to speak. And I think we're there. Oh, good. Thank you.